Happy morning, students. Today we are going to see a short video on cardiac output. Okay, so what is cardiac output? It is the amount of blood ejected by each ventricle per minute. So the normal value is 5 to 6 liters per minute. It is given by the product of stroke volume and heart rate. So what is stroke volume? It is the amount of blood ejected by each ventricle per beat. So this value is around 70 ml. And what is heart rate? Heart rate is number of beats per minute. It is 70. So the product is 70 into 70, 4900 ml or 5 liters per minute. So this is the value of cardiac output, which is given by the product of stroke volume and heart rate. So coming to the factors affecting the cardiac output, what are the factors affecting the stroke volume and heart rate? It is going to affect the cardiac output. So the very important factors affecting the stroke volume, that is the amount of blood ejected by each ventricle per beat, is mainly by three factors. One is preload, other one is afterload, other one is the muscle contractility. So what is preload? Preload is nothing but the end diastolic volume, that is the volume of blood remaining in the ventricle at the end of diastole, that is at the end of relaxation. And this end diastolic volume is directly proportional to the stroke volume, and which was given by the Frank-Starling law, which states that the force of contraction is directly proportional to the initial length of the muscle fiber within physiological limit. Here the end diastolic volume determines the initial length of the muscle fiber. If the volume is more, there will be more in the initial length of the muscle fiber, like an elastic band. So this volume is going to stretch the fiber and it will increase the initial length of the muscle fiber. Automatically the force of contraction will increase and stroke volume will increase. So this end diastolic volume in turn depends on three factors. One is the venous return, second is the ventricular compliance, and third is the atrial pump. So what is venous return? That is the amount of blood reaching the ventricle by the vena cava, that is constituting the venous return. And this blood which is returning to the ventricle is decided by three factors. One is the skeletal muscle pump in the lower limb, second is the abdominal pump, and third is the thoracic pump. So skeletal muscle pump in the lower limb, so when in the lower limb muscles, when they contract, they will squeeze the blood in an upward direction because of the presence of valve which allows one-way flow from bottom to up. So this will increase the venous return. Second is the abdominal pump. So during inspiration, the diaphragm will be moving down, giving an abdominal pressure that will squeeze the veins and the blood will be pushed upwards. Third is the thoracic pump. So when the lung expands, there is a negative pressure which is created, and this negative pressure acts like a suction and it will pull the blood upwards through the central veins. So this is the role of the three pumps: skeletal muscle pump in the lower limb, abdominal pump, and thoracic pump. Second factor is the ventricular compliance. Ventricular compliance is the expansibility of the ventricular muscle fibers. So this expansibility is in turn controlled by the pericardium. See, the pericardium is a covering, and any diseases of the pericardium, it is going to restrict the expansibility of the ventricles. So this expansibility or stretchability, that is also going to determine the initial length. So that is coming under ventricular compliance. And third is the atrial pump. So atrial pump constitutes about 15 to 20% of the ventricular filling. So ultimately, when the filling is going to increase, the fiber length is going to increase, and that is going to affect the stroke volume. So all these three factors, that is venous return, ventricular compliance, and atrial pump, they are going to determine the end diastolic volume, and this end diastolic volume is directly proportional to the stroke volume as per the Frank-Starling law. The next factor is the afterload. Afterload is nothing but the peripheral resistance that is mainly offered by the aorta and the blood vessels, and here the peripheral resistance is inversely proportional to the stroke volume, also cardiac output. So This peripheral resistance in turn depends on two factors. One is the diameter of the aorta vessel and viscosity of the blood. So the diameter, when it is very narrow, it is going to give more resistance, and when the viscosity of the blood is very high, it is going to give more resistance to the output. So afterload is inversely proportional to the cardiac output. And the third important factor is the muscle contractility. So the muscle contractility is directly proportional to the stroke volume. So more the muscle contracts, more will be the stroke volume and more will be the cardiac output. So this muscle contractility in turn depends on three important factors. One is the muscle mass. When the muscle mass is bigger or thicker, it is going to have more force of contraction. And second is the autonomic nervous system. So the autonomic nervous system, sympathetic, it is going to increase the contractility of the muscle, thereby increasing the stroke volume. And third is the humoral factors, that is hormones and chemicals. So the hormones like thyroxine, which will stimulate the myosin ATPase enzyme, that is going to increase the contractility of the muscle. And then some drugs like digitalis, will increase the muscle contractility. So we have three important factors to sum up. One is the preload, other one is afterload, other one is the muscle contractility. So these three is going to affect the stroke volume, and ultimately it is going to affect the cardiac output. And regarding the heart rate, so the factors affecting the heart rate, mainly the autonomic nervous supply. Sympathetic will increase the heart rate, and here one important point is the heart rate alone cannot increase the cardiac output. So when the stroke volume is increased along with heart rate, it will increase the cardiac output. So because in severe tachycardia, increase in the heart rate, the duration of diastole is compromised, so cardiac output will be reduced. So we have to give some time for relaxation. So heart rate as such does not directly increase the cardiac output. When heart rate is increased along with stroke volume, cardiac output will be increased. So coming to this, to have a look on this all the factors, we have two regulations of the cardiac output. There are two type of regulation. One is the heterometric regulation, other one is a homometric regulation. Heterometric regulation is nothing but regulation done by the preload, that is change in the length. Hetero means change and load, metric means length. So change in the length, that is change in the cardiac output, that is done by the preload, which was explained by the Frank-Starling law. Homometric regulation, it doesn't depend on the change in the length, and it is mainly determined by the afterload, that is a peripheral resistance, and other factors like hormones and drugs. These are all not involving the change in the length as a factor. So these are all coming under homometric regulation, that is the length is not a factor here. So there are two regulations, heterometric regulation and homometric regulation. Okay, so to sum up, today we saw about cardiac output, definition of cardiac output, and what are the factors affecting cardiac output. Because it is a product of stroke volume and heart rate, factors affecting stroke volume will affect the cardiac output. Factors affecting heart rate have a minimal role in affecting the cardiac output. And we have preload. Preload is simply, it is a load acting on the ventricle before it contracts, whereas afterload is the load acting on the stroke volume or the heart after the contraction. So preload is end diastolic volume, afterload is peripheral resistance. Then the third factor is the muscle contractility. So this we complete, and we have two regulations. One is heterometric regulation, other one is homometric regulation. Okay, thank you.